Secondary hypertension refers to an elevated blood pressure caused by an underlying, identifiable, and potentially reversible condition. While long thought to affect only 5 to 10% of patients, clinical guidelines highlight that its true prevalence may be as high as 10 to 35% in specific subsets, such as those with severe or treatment resistant hypertension. Recognizing secondary causes is crucial. Delayed diagnosis can lead to irreversible vascular damage and disproportionate hypertensive mediated organ damage. Screening the entire hypertensive population is neither cost effective nor clinically practical. Investigation should be targeted toward patients presenting with specific red flags. Resistant hypertension, uncontrolled blood pressure despite adherence to optimal doses of 3 antihypertensive agents from different classes, including a diuretic. Age of onset, abrupt onset or severe hypertension developing before age 30 or after age 55. Acute destabilization, sudden severe loss of BP control in a patient whose numbers were previously stable and well regulated. Disproportionate target organ damage, severe target organ damage, example advanced retinopathy, left ventricular hypertrophy, or renal dysfunction, that seems excessive for the known duration or severity of the patient's high blood pressure. Specific clinical clues: unexplained hypokalemia, abdominal bruit, or episodic spells of sweating, palpitation, and headache. Go through some important causes of secondary hypertension and their management. Primary aldosteronism, Cont syndrome. Once thought rare, primary aldosteronism is now recognized as one of the most common endocrine causes of secondary hypertension, particularly prevalent in patients with moderate to severe or resistant hypertension. The primary screening tool is aldosterone-renin ratio. Guidelines emphasize that screening should occur even in the absence of hypokalemia. To avoid unnecessary screening barriers, patients can continue most of their baseline antihypertensive therapies during testing, with the critical exception of mineralocorticoid receptor antagonists like spironolactone or eplerenone, which must be discontinued. A positive aldosterone-renin ratio is confirmed via dynamic testing.